Familial hypercholesterolemia is the commonest autosomal dominant condition affecting man. So the current wisdom suggests that the prevalence of this condition is about 1 in 200 to 1 in 250 in general populations. The prevalence of homozygous familial hypercholesterolemia is about 1 in every 1 in 600 or so thousand, rather than the 1 in a million that we believed. So these are individuals who, by and large, have defects in the LDL receptor that accounts for most of the problems of this genetic condition. And what it means is that they have much higher levels of LDL cholesterol from birth, well actually from utero. And therefore they have many more life years of exposure to high LDL cholesterol, a faster rate of atherosclerosis. So without treatment, somebody with homozygous FH is unlikely to live beyond the second decade of life, and somebody with heterozygous FH will develop myocardial infarction prematurely in early to middle age. So this is a public health challenge. So the biggest challenge is, if you don't find them, you can't treat them. So if you look at countries where there is a screening program, the Dutch are the best. They identified, based on historical prevalence of 1 in 500, about 70% of their population with FH. Based on a prevalence of about 1 in 200, this number is probably about 30%. The majority of the world have a detection rate of less than 1%, and partly it's because of a lack of awareness, a lack of understanding, a lack of regular screening, cascade screening where you find the index case and you bring their relatives back and you start them on treatment. So that's a huge, huge challenge. We have some treatments already that are good, namely high-intensity statin therapy, ezetimibe, but only about 20% of patients on these treatments, because the starting level of LDL cholesterol is so high, will actually get anywhere near the guidance targets of an LDL of 2.5. Undoubtedly, PCSK9, the mode of action is with using a monoclonal antibody that mops up circulating levels of PCSK9. This is a protein which essentially binds to the LDL receptor and stops it recycling, so you have fewer LDL receptors. Now, with these monoclonal antibodies to PCSK9, we will end up with more receptors that will remove more LDL from the circulation. So now these patients with FH, based on trial data that we have, somewhere between 60 to 75% of patients with FH now will get down to levels of LDL below 1.8, 2.5 millimoles. We've never ever been able to reach these levels with conventional treatment, even when we've utilized this. So this is a game change and a whole revolution in the treatment of FH. The main problem now actually remains, we've got a treatment that works, is finding those patients. Well, the PCSK9s have, or just are about to get approval. We have 2 compounds that will get approval in North America and Europe. It's imminent. In some areas it's already happened. In terms of actually putting them into clinical practice, it takes a little bit of time. So in some parts of the world there will be discussions around the cost of these agents, there'll be pathways, who are the patients, so we've got to get that. So doctors, if they want to use this in patients, have to identify those patients. The license will be for FH initially and hypercholesterolemia with high cardiovascular risk. So we've got to identify those patients, agree a protocol and a pathway, and ensure that appropriate funding is available to actually fund this. But the biggest challenge is actually you can't treat this condition unless you find it. And so that's where, for example, we in the European Atherosclerosis Society, we've established the EAS FH Studies Collaboration, a global collaboration of 80 countries using registry data to determine how FH is detected, managed, so that we can actually change policy, develop ICD codes for FH which don't exist, and actually try and mandate screening and better identification, because we're now going to get the tools to treat these people better.